One of the key things we've learned is if you treat everybody the same, it sounds good, perhaps in theory, but in healthcare, terrible idea, because we all have a different experience with healthcare and a different level of trust, and the social determinants impact us uniquely. And if a plan treats you and me the same, shame on them. Our healthcare system doesn't do a good job of creating that more personalized experience.
Welcome to The Other 80. I'm Claudia Williams. On this podcast, we talk about how we can build health in America beyond medical care. Only 20% of overall health is determined by medical services. We are here to talk about the other 80%, housing, food, social connections, and how to move rapidly and equitably towards whole person health in this country. The U.S. is home to more than 330 million people. Collectively, we speak 350 languages. We live in more than 9 different climate zones. We are all products of where we are from, how we were raised, the foods we eat, the cultures we celebrate. Each and every one of us is completely unique. And so it's becoming more and more obvious that our cookie-cutter approach to medicine is not going to suddenly deliver whole person health. We need a system that accounts for a person's entire self. And that's why I've invited Abner Mason to join the podcast today. Abner has spent decades working to reduce the barriers to care faced by underserved people, locally, nationally, and internationally. He's the founder and CEO of SameSky Health, a company devoted to helping health plans and providers understand and meet people's unique needs. Abner believes that as a nation, we won't be able to address equity or improve quality until we can build more trust with patients. And it's not just a matter of patients trusting the healthcare system. It's a two-way street. So the health system must also trust that patients are experts in their own health and lives. That gap is something SameSky Health is working to address. So please welcome Abner Mason to The Other 80. I wondered if you could start by just saying your name and share with our listeners what's important to know about you.
So that's a great question. So my name is Abner Mason, and what's important to know about me is, I guess that I'm really committed to health equity and making some positive change in our healthcare system, and I'm willing to try anything and do anything and work with anybody to make that happen.
I've seen that in action. So one of the topics that we're going to be digging into, the podcast broadly is looking at whole person health, meaning the integration of social care and medical care and all of the policies, programs, companies that are bringing that to life. And one reason I thought you'd be just a great guest is that equity underlies so much of that work, and the need to increase health equity and be smart and pragmatic about how to do that, not just talk the talk, but walk the walk. And then the second side is that a lot of the innovations and work that's making these new programs happen are companies that have really dug into the Medicaid space. We had a great opportunity in the last episode to talk with Andy Slavitt, who obviously brings together both a deep understanding of policy, but also is actively investing in companies in the Medicaid space. So I thought this would be a nice counterpoint to that with your company, SameSky Health. Really, a great deal of your business is focused on serving Medicaid members, but also serving the companies that support Medicaid members, the health plans and other folks. So a bunch of the questions will have to do with that kind of the investment landscape. What's it like to be a CEO in that context? Advice you might have for other companies wanting to dig in. And then later on, we'll be talking about really the equity part of this conversation. So maybe just start with, it'd be great to hear more about SameSky. What is the company? What is the opportunity you're really focused on, and how do you go about pursuing that?
Sure. So thanks again for inviting me to have this conversation. So SameSky Health, we are a health equity technology platform company. And what that really means is that we're very focused on helping our clients. And today that's primarily health plans and the Medicaid, Medicare Advantage and Exchange lines of business. So it's the government lines of business that we focus on today at SameSky Health. We are focused on helping those clients, those payers to build a more trusted relationship with their members. One of the challenges that health plans have is that there's just not a lot of trust between healthcare members and I would even be more general, healthcare consumers and the healthcare system. So health payers like the ones we work with, they really need to build a more trusted relationship with their members because they need to get the members to do things in order for the plan to be successful. And I would define success as both, the plan's performance as a plan, but also the improving health of the members. In order to be successful in both ways, the plans need to get members to do things. They need to get them to engage in their health care. That means, for instance, and we'll take Medicaid as an example, getting a mom or a grandmom or whoever's responsible for a baby to come in and get the combo 10 vaccination. So between the time a baby's born and 24 months, someone has to bring that child in. And how do you get the attention of that member who is low income by definition because it's Medicaid? They're struggling to keep food on the table and a roof over their heads. They're probably healthy, and so and they don't get paid for time off to go into the doctor to have the baby to get the combo 10 or to get that well child visit. And if that child is healthy, that parent is saying, okay, if I go in, it's a half day or all day experience. I've got other kids. I might have to drag them along as well. I don't get paid for this. I'm working paycheck to paycheck. It's a struggle, and there's a lack of trust and understanding, and so that's where we come in at SameSky Health. The plans hire us to say, "Hey, SameSky Health, can you reach out to that mom, let's say, and make sure she understands, even though her 3-year-old is healthy, he's running around, like a crazy kid. She's like, he's healthy, he's out playing, he's doing everything. We've got to explain to her why a well child visit is important. Even though the child appears healthy, there may be issues that if we don't catch them now, they could impact that child's life forever. And so you can't see it, but we need to check. And so that's what the well child visit is for, right? So we've got to say to that mom, it's number one, what is this well child visit about? Number two, build a trusted enough relationship with her so she'll tell us why she's not likely to bring the child in. It may be she can't get time off from work. It may be she doesn't have transportation. It may be she doesn't have a primary care provider that she trusts. It may be she's got some family issues, like that she can't leave some kids at home and bring this kid. Whatever it is, there's something in the way of her coming in for that well child visit. And that's our job, is to engage her, build trust, and to understand what that problem is and to help navigate her into that well child visit. The interesting thing about SameSky Health is that we're doing this at scale. We're doing it for millions of people at a time. And so that requires technology that allows us to build that more trusted relationship. And that's what we built at SameSky Health. We built a technology platform that allows us to ingest a lot of data, public data, private data, claims data. We add to the team we've built that understands how different people consume healthcare. And we have a philosophy that's really based on this view that you need to understand who people are at a deeper level, and the data helps us do that, a deeper cultural level. The situations on the surface may not look that different, but they are fundamentally different at the individual level. And that's what we focus on, understanding that and then helping navigate that mom so that 3-year-old comes in for a well child visit.
I'm curious, the concept of trust has come up a lot in the conversations I've had. And I think the lack of trust, as you've mentioned, obviously there's going to be a tailored approach to each person, but are there any general things you've learned about how better to build trust and the ways we get that wrong today in other healthcare experience? What are your top lines about how to go about that?
So the key thing that we've learned, we've been doing this for 10 years now, so we've learned a lot, and we focused, from the very start on low income, low health literacy, people who are impacted by the social determinants of health. Our sweet spot was always that sort of Medicaid type population. Now today we serve everybody, from lower income to higher income, we serve everybody, but our roots and our sweet spot are those low income people. And a couple things we've learned, and this is going to sound obvious, but it hasn't been obvious. Number one thing we've learned is that people, and it goes to your point about whole person care, people are not quality measures. And we're guilty of this at SameSky Health in our early days. Health plans typically have goals that they want to achieve with the member. They want, and go back to that same example, that mom bringing that child in for a well child visit. It's really important for the plan to get that child in the 12-month period, because they're measured on a calendar year, and the plan is their performance, their ability to get paid, their ability to win new contracts, how they are measured as a plan, are all dependent on getting that 3-year-old into a well child screening in a 12-month period, a calendar year period. And so because of that, so much of the way that healthcare has worked up until now, and still does in many instances, and again, we're guilty of this, you got to get that child in. So the priority for the plan and for the partners the plans work with, like us, is that well child visit. But if there's no food in the refrigerator, and that household, they are having food insecurity, it's just a non-starter, really, to really get that mom to prioritize a well child visit for a 3-year-old who to her looks healthy. And so the first thing we learned is we need to figure out what's important in that woman's life, in this instance, using that same example. What's her priority? Because what we found is that if we can understand what her priority is first, and then help her with that priority, we can build trust with her that allows us, maybe in month 2 or month 3, to say to her, and by the way, there's a well child visit that needs to be done. And it really is all about treating her like she's a person, not a quality measure that needs to check the box. We'll get to that. And one of the things I'm just happy with our clients, our plan clients, is they're willing to be patient now. We say to them, look, I know you're hiring us to get her in for a well child visit because that's what you need in your performance, or it's a star measure, or whatever the measure may be. But increasingly plans say, we will give you the room to build a trusted relationship, because we know, and we've proven this, if we give you that room, you will get better results with the well child visit, or better results with the star ratings, because you've built trust. So I think one of the key things we've learned is that if you treat everybody the same, it sounds good, perhaps in theory, but in healthcare, terrible idea, because we all have a different experience with healthcare and a different level of trust, and the social determinants impact us uniquely. And if a plan treats you and me, Claudia, the same, shame on them, because you and we're very different, and the plan should. And the rest of the health system as well should follow this. We ought to treat people like who they are matters, and that means taking the time. And it's not easy, but we have the tools to do it, to understand who that member or that healthcare consumer is. It's not just about plan members; it's about patients in general and people in general. We've got to treat our healthcare system doesn't do a good job of creating that more personalized experience.
Yeah, I know we both share lived experience working in Africa. And I know when I ran a child survival program in Burkina Faso and didn't speak the local language, we hired local young women who lived in those communities and took their motorbikes around and did home visits. And the insights they had about people's, the kind of real experience they had, and the reasons that people may not eat or would eat a certain way, but not another way, to me were astounding. And it takes time. Like you said, it takes openness. It takes trust both directions. Like if I'm so busy trying to fill that little quality measure, I'm not actually trusting that you and I are on the same page. And it feels very undermining. Right. If you're that mom trying to figure out, you want to help your kid. Like there's no question you want to help your kid.
Right.
Interesting.
And that whole perspective you just shared is really one that we need to keep in mind, because sometimes there is a kind of, these people are behaving badly, meaning the consumer, the health member, and we need to make sure that we don't take that attitude. It's kind of a judgment, like, why doesn't she care about her kid? Because she's not bringing him in, and we don't understand she's balancing feeding him versus a well child visit that's a bit esoteric when you got to deal with food that night. And so it's really important not only that we not judge, but that we keep judgment out of our communications, because it's so easy to have that in there. So what you just said is really beautiful, and it to me it represents the humility that we need to have as we are doing this work. We need to be open to learning and not letting some biases creep in,
and to see the intelligence that person has around the choices they're making as being phenomenal. But how can we help them access other choices? Like sometimes,
as opposed to judging, right, exactly. Right. As opposed to judging, how do we help? We, come in with an open heart and open hands and a willingness to, as you said, understand. People's, they're sometimes making very intelligent choices given what they think their options are. And so what we need to do is expand their options, as opposed to judging them, expand their options.
Exactly. Scooting back a little bit and thinking about the Medicaid space as a company leader, as a CEO, a lot of folks are advised when they're starting companies to avoid Medicaid. It's too hard. You can't access the market. There's all these issues with it. And I'd just be curious to hear from your perspective as a company that started with Medicaid. How do you view the challenges of working in that space? And how have you addressed some of those challenges in the way you work, and what kinds of clients and what kind of business you go after? And then we'll get on to, in a minute, to what advice you would give. But just what do you see as the challenges, and how have you gone about addressing those?
Well, you described some of them. Working in healthcare in the US, because it's highly regulated, is just hard in general, working in healthcare. And then within healthcare, if you choose to work in the Medicaid space, I'm joking when I say this, but you are a little crazy. It is really, it's like picking the hardest of the hard spots to do your work. And so it is really difficult. Unlike Medicare Advantage, for example, which is a national program, so you can scale your solution more quickly. And a key thing for companies and innovators and investors is this concept called scale, meaning how do you grow the business? How do you grow the revenue? And so everything is about scaling. And frankly, the Medicaid market is not set up to scale. Because unlike, again, Medicare Advantage, which is a national program, Medicare Advantage is a state, as you know, state-federal partnership, but the states get to kind of write the rules in every state. And so every state is different. And it makes it very hard to scale your solution. And so it's one of the hardest places to choose to do healthcare, work. That's the negative, and I'm just being honest. The positive is there's no better place to work if you want to make a difference in improving our healthcare system in the U.S. And if you care about creating a healthcare system that works for everyone in our country, regardless of what they look like, what they talk like, where they come from, or how much money they make, if that is something that's in your heart to do, there's no better place to work than the Medicaid space. So I know I've just said two opposite things. It's a terrible place to work, but it's also the very best place to do work. This is one of those instances when both are true. And so for people who don't have a heart for this kind of work, and because it's going to take longer, it's going to be harder. It's going to be harder to get funding. Thank goodness for Andy Slavitt, who you just mentioned, because I think the new fund he's running, Town Hall Ventures, is doing a fantastic job of focusing on solutions for low-income people in particular and underserved populations. And even before he started Town Hall, he was encouraging investment in that area. But the truth is, there's not nearly enough investment, even still. I saw an article just the other day that was in Health Affairs, and it looked at the investment. I think you probably saw this, in the investment in Medicare Advantage solutions and the investment in Medicaid solutions. I mean, a tiny, tiny fraction of the amount of investment dollars is going to companies and innovators who are building solutions for Medicaid versus Medicare Advantage. And the reason is there's a ton more money in Medicare Advantage per member money available for the plan to spend and invest in solutions on the Medicare Advantage side than the Medicaid side. So I hope I'm not being negative, but that's just the reality that we face now. But the need is enormous on the Medicaid side, and I think particularly the need for innovation, for new solutions that are going to be effective.
So let's talk about scale. How do you scale in that environment where each state has a slightly different approach, even different plans? So what do you do?
It's tough. It really is tough. I have scars, many scars from trying to do this. So we learned early on, and this was a mistake I made, and I try to share it as much as possible so that other entrepreneurs and founders don't make the same mistake. I was more focused on the solution we were building when I first started the company than I was on how that solution could solve the problem for clients. So one of the first things that I would encourage anyone to do, and I didn't do this enough, so I've got scars from it, is you have got to go and talk to who you think are going to be your ultimate customers. Because I can almost guarantee you that what you think they want and will buy is different than what they want and will buy. So it's really important to talk to that end user customer. For one thing, you may find out that you've got the wrong end user in mind, that what you're building they're not ever going to buy it. And it may be a different customer you need to go for. But you certainly need to make sure early on that you are talking to customers. And there's this kind of funny conceit almost that founders have, and I had a bit of it, is that when you have an idea for a company, you think it's like an incredible idea. And of course you do, because you're about to dedicate your life to it. And you got to convince other people. You got to hire people and convince them to join. So you got to believe in this thing. And part of that comes this view that I got to be very careful about who I talk to about it, because someone's going to steal my idea. And yes, there is probably, a tiny bit of truth in that, but not nearly as much as people think. You should go and talk to people who you think are going to be your customers, and don't worry about them stealing your idea, because there's a million ideas out there. There just aren't great, entrepreneurs and teams to bring them to reality. What you want to make sure of is that your idea is one that is going to actually resonate in the marketplace. So I would say really important, talk to the end user. I didn't do that enough initially. And so fortunately, I figured it out before I got totally, burned. But early on, I was more enamored by the solution, and I didn't talk enough to the end user, the customer.
Can you give just quickly an example of something that proved to be not interesting to your customer, and something else that you had no idea would be interesting?
So my first idea, this is for what is now SameSky Health. We rebranded the company. It was Consejo Sano. My first idea when I built the company was it was going to be a telehealth type solution. So I was focused on Latinos. That's why the name was at the time Consejo Sano. And I had a solution. I had made a deal with a company in Mexico. It was the largest telehealth company in Mexico. They were a global best practice. McKinsey had done a study and named them a global best practice. This company based in Mexico doing telehealth in Mexico. So, doing telehealth in Mexico, a huge company. They wanted to get into the US market. And so I made a deal with them, and I said, I'll build a solution in the US, and we will use your doctors in Mexico. So you could be in the US, you could tap your phone and talk to a native Spanish speaking doctor within 10 seconds, anywhere in the US. And it wasn't to replace the US doctor, it was the complement. A lot of Latinos, a third only speak Spanish, another third are uncomfortable in speaking English about healthcare issues. So you've got, tens of millions of people. So I had this idea, let's build a solution for them. That's what it was. And it sounded like a great idea. I remember going to a large FQHC in California, and the CEO set me down and he said, Abner, I love what you're doing, but if you do that, I can't get paid, because the only way I get paid is if my patients come into my clinic. So think about this, a solution that is like $4 versus $1,000 is an example. But he basically said, Abner, I can't use you, because if I contract with you, even though it's better for my patients in this instance, and it's better for society, taxpayers, I will go out of business because I can't get paid. And I remember sitting there across from his desk, and my face, I could feel it, just I was crestfallen because I had this wonderful solution, but it wouldn't work because I hadn't figured out, I hadn't talked to him in advance that he can't get paid if he uses me. And so then he said, though, and I'll thank him forever for this, I was just stunned. And he said, but the way you're reaching out to people to tell them about this service, the phone call to Mexico, if you could reach out to my patients and get them into my clinic, because I get paid then, and I'm having trouble getting that mom to come in for a well child visit for all the reasons we talked about earlier. So if you could reach out to her in a culturally, linguistically appropriate way, not to get her to call a doctor in Mexico, but to come into my clinic, this week, we can do business. And that changed the model for Consejo Sano, what is now SameSky Health. It was because that CEO of that FQHC was kind enough, as opposed to just blowing me off. He invited me in and said, what you have built, I can't use. But if you change it a little bit, it could be a fabulous solution. And that's what SameSky Health has become.
Maybe on that same topic of policy, I've often been of the view that policy creates business opportunity. And I think you've described some of those examples around equity and even around the quality measurement. Is there a set of policy changes that are going on now that are creating new opportunities, and what are those?
Yeah, so I think one thing that I find very exciting is I think we are at a point in the country with our healthcare system, and it's a good thing. It should have happened a long time ago, but it didn't. We have always known that our system wasn't really equitable, and that there were a lot of health disparities. And we've known it. We've talked about it for decades and decades, but we really didn't take the steps to do something about it. I believe, and I could be proven wrong here, but I hope not, that we are at the start of our country really starting to make progress on addressing those disparities, at least potentially, and creating a more equitable healthcare system. And to me, it's like a 3-phase process. The first phase is collecting data, particularly race, ethnicity, and language data. I know you know it, but we don't have that data for healthcare consumers or for members, for patients across the country. Race, ethnicity, language. It's amazing it's such a low percentage health plans, for instance, have sexual orientation and gender identity. It's almost non-existent in terms of that data being collected across the country. And then social determinants of health data. Does a person have food insecurity? Do they have housing insecurity? We don't have that data. We've never collected it either at all, or certainly in any consistent way. And yet we know, for instance, that a person's health is like 80% the SDOH related stuff, the non-clinical stuff, versus what happens in an actual clinical setting. So all of that thinking and knowledge and experience is coming together now. And I'm hoping that regulators at the federal and the state level have gotten together with key, accreditation organizations like NCQA. And I just think it's a great moment. Health plans across the country are slowly but surely being required to collect this data, starting with race and ethnicity, and soon sexual orientation, gender identity, as well as SDOH data. Health systems are going to be required to collect it. They call it health-related social needs. All across the healthcare system, we're starting to collect this data now. That's phase 1, collecting. Phase 2 is requiring all the healthcare stakeholders to report quality measures stratified by these demographics. I mean, think about this. For the first time in our nation's history, we're going to be able to, for example, to track breast cancer across ethnic groups across time. We know there are disparities that exist, but there are no metrics around them. So the second phase of this effort is going to be stratifying, quality measures and really being able to, over time, measure disparities. And step 1, collecting. Step 2, reporting with stratified, is going to create the opportunity, which is step 3, which is once we know where those disparities are, it's going to create an enormous need for new solutions. Yes, some old solutions can be applied to those disparities, but I think that there's going to be a need for new solutions as we are able to really understand what's going on with these communities. So to your question, to me, that's an example of policy leading to the need for new solutions, because if the old solutions, if we didn't need new solutions and the old solutions worked, we wouldn't have the disparities that we have today. So clearly there is a need for better approaches, particularly approaches that use technology. So that's one example to me of policy finally, getting aligned correctly and creating the need for new solutions.
And it's interesting, the what we were talking about earlier around trust very much comes to bear on this, because what I've heard a lot from plans and providers are, they say, well, we ask those questions. Well, two things happen. One, they ask the question, but the person doesn't want to answer because they don't trust the information will be used in a appropriate way. Or I've heard this a lot, providers never ask because they don't feel comfortable asking. And so in a trusted relationship like you're able to create with a member, you have a person who's trained to ask these somewhat sensitive questions in a way that's super supportive, embedded in a relationship where there have been multiple plays of trust that have built over time. So I've heard this a lot, though. A lot of times those fields are blank because the question was never asked.
We live in the country that we have. We can't, go back and redo it, right? So we're in 2023 and America is as it is. There has been a lot of distrust, and people are uncomfortable talking about certain topics or even asking the question. And I get it. It's like a chicken and egg. You need to know more about people to create a more personalized relationship that itself can build trust. But if you don't have the trust, how do you get the person to tell you the stuff that you want them to tell you, so that you can build the trust? It is just chicken and egg. It's not easy. I'm not saying it's simple, but we are starting to figure out to sort of crack that code at SameSky Health. We're getting people to tell us, and a lot of it has to do with how you engage people, what you tell them up front. But with all of that said, hopefully I'm coming across as positive, because I do think this change that I've described of really getting serious about collecting data that's going to allow us to uncover disparities is a good thing for our country. I do want to, I have to be honest, there is a bad thing that I'm seeing and hearing in the country. And that is, for example, folks who are trans or even drag queens now are becoming this target they're becoming a target for politicians. Some states have even said, they're gonna try to not cover with their Medicaid program or state funds transition for trans people. This idea of taking one group in society and starting to target them, that's not. It has a really negative effect on people being willing to be open about, for instance, their sexual orientation and gender identity. If you think giving that information is going to put you on a list that you're going to be sort of targeted, you're not going to provide that information. So that's a negative thing that's happening now. And I think those of us who disagree with that need to lift our voices now and say that it's wrong. And we are going to, fight it, and we're going to not, to the extent we have power and influence. And I'm looking at health plans here and their leadership, and they need to make clear that that's not who they are and that's not what they're going to do. But the rest of us have voices. We all have a voice. It's not like you have to be governor to have a voice. We all do in different ways. We just need to, make our voices heard.
Mm-hmm. Interesting. Speaking of having a voice and making it heard, I know you've been talking a lot. You're a very effective communicator and have really raised up this issue of the Medicaid redeterminations and the impact that it may have on poor people. And many people are aware of this, but not everyone is. So I wondered if you could just give us kind of an overview of what's at stake here with the upcoming redeterminations in April. And what do you think needs to be done to ensure that we don't end up with huge losses of insurance?
Yeah, so a good, the pandemic, the COVID pandemic was horrible, but one of the good things that happened is that, regulators stepped up and said, hey, we need to make it easier for people during this COVID period to make sure that they, for instance, can keep their health insurance. Well, now the public health emergency is coming to an end. And in that period, a lot of people lost their jobs and became eligible for Medicaid. So you had the rolls increase, and people who were on the rolls didn't go through redetermination. Well, starting in April, that public health emergency is officially over, and states, all 50 of them plus the territories, have to go through a process with the Medicaid members in their state to get them redetermined. It's never happened before where people had to do this kind of effort. Depending on who you listen to, and there are a lot of experts in the field. 15 million people are potentially could lose their Medicaid, their health insurance coverage, either because they don't know they have to go through this process, and it'll be hard to communicate with them to get them through it, or they might not qualify for Medicaid, but they could qualify for the exchange, but they don't know it. Or maybe they got a job, but the job doesn't pay insurance. It's a small employer. And so that would make them qualify for the exchange. So there's this huge millions and millions of people, up to 15 million, who have to go through this process. And if history is any guide, people are saying, the experts are saying you could see, 5-6 million people lose their insurance coverage, health insurance coverage unnecessarily. They qualify, but they couldn't be reached. And add to that a recent study that Robert Wood Johnson came out with, Robert Wood Johnson Foundation, just about 2 weeks ago. 62% of folks on Medicaid don't know they have to go through this process. 62%. To the latter part of your question, we need the states and the health plans to partner in a way they've perhaps never done in the past. And we need to figure out a way to reach out to people. If 2/3 don't even know they need to go through this, we are about to, have a horrible problem. And think about this: if we allow the end of the public health emergency to create another emergency for low-income Medicaid folks, shame on us, right? We've had time, we know it's coming, and so we need to put in place the steps to make sure that people know they need to go through this process. And there's an easy way, what I'd call a 2023 method, not a 1970 method. It needs to be flexible. It needs to take into account people who are comfortable doing things online or via their phone. Also, we've got to find some other avenues for people who are just not comfortable with that or don't have that ability. So we are focused on it at SameSky Health. I'm fearful that states and plans aren't moving quickly enough to put in place the procedures to get us through this.
I would think they would both be very motivated. What do you think those barriers are to them stepping up? Just that it takes time to...
I think it takes time. Mm-hmm. I think that many of them are perhaps not aware of how much change there's been in that population. So, for instance, during the pandemic, a lot of low-income people moved. Either they got foreclosed on, a huge foreclosure crisis, which is continuing, or they just couldn't afford their place because they lost jobs and income, and they didn't update their address information. So something as as important as, but as simple as address information is getting in the way. Now, one good piece of news, and we also should highlight that the FCC, the Federal Communications Commission, recently issued a declaratory regulation or guidance that health plans can use text messaging to connect with their members only for the purposes of redetermination. Now, that is a big step forward. That's what I call a big step toward getting into 2023 from doing things the old way. Now, unfortunately, they've limited it to redetermination, but we should be grateful for that. That when our government does something right, we should really be grateful. So good for HHS and good for CMS and good for FCC for doing that. It's a big step forward, but that is an example of plans didn't have that capability until just, a month or so ago when the FCC ruled that they could do it. They weren't planning to use text messaging because they weren't allowed to, many of them, most, I would say. Now they can for redetermination. So that's a good step forward.
Okay. All right. To wrap up, the first question is, what's a leadership lesson you've learned the hard way?
I'd say asking for help. There's this weird balance between, when you're a leader, between showing leadership and giving the sense that you know what you're doing, because people expect leaders to know what they're doing, but recognizing that you don't know everything and you sometimes don't have the right answer. And so it's really important to first accept that you're going to need help and be willing to ask for help. And then the second part of that question is you got to know who to ask. Not everybody is is the right person to be asking for advice. You really got to curate your network and find people that you that you can have a relationship with, that you trust, but who know what they're talking about, so that when you can feel confident of the advice that you're getting. But asking is, you gotta be willing. It doesn't matter how smart the people around you are. If you don't ask, it's no good to you. So you gotta be sort of humble enough to recognize you don't have all the answers. You can't, and it's okay. I don't know anybody who has all the answers. So you gotta ask for help.
It is I think as a recent CEO, I know that so much of our energy is spent building confidence and being optimistic about the future. And it sometimes feels like asking the question is admitting we don't know those answers, that we're trying to get everyone still around the campfire. And I'm reading a book about Winston Churchill that's actually very relevant, where he would say, like, things are dire and this is our moment in time, and sort of being able to like be frank about the reality of the situation, because nobody wants to feel like they're hearing something that's not true. But at the same time, reminding people of the importance of the mission and the possibility of being successful, even if we haven't gotten there yet.
Exactly right.
It means having good sleep and good food and good rest and all those things become really important, because I don't know about you, but I find that if I have those things, being able to respond with that openness is a lot easier.
Agreed. 100%.
Okay. Final question. What's a question you wish I had asked? And what would have been your answer?
Oh, that's a tough one. Maybe, what I think the future looks like for healthcare in say 5 years in the U.S. And my answer, today, I'm optimistic. I think for the reasons we talked about, I think that we're making headway. People are leaning into the steps that we need to take to create a more equitable healthcare system. So I'm very optimistic about where we're headed.
Wonderful. Thank you so much for joining, and I hope our paths cross again very soon.
Absolutely.
You're probably on the conference schedule right now, I can imagine.
Yes.
And I hope it's going well.
Very much so.
A big thank you to Abner Mason for sharing the important work he's doing, building a healthier and more equitable world. I left this conversation thinking a lot about data. To understand someone's whole self, we need a lot of facts: their race, their past trauma, and whether they have enough food and safe housing. But for too many people, those facts have delivered harm, not help, in the past. How can we ensure that the data we are collecting will help people, not create discrimination and harm? That's a big question we will be exploring in future episodes. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. I've included resources in the show notes that you might find interesting, including a case study on how Abner's company helped increase vaccine equity in California. There is more information on my background, the podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.